Welcome, everyone. In this presentation, we will explore practical principles for avoiding common diagnostic pitfalls in neurology. The central message is that accurate neurological diagnosis does not depend only on recognizing diseases. It also depends on disciplined clinical reasoning, careful assessment, repeated reassessment, and continuous vigilance. A safe diagnosis is not a single moment. It is an evolving process that requires humility, structured thinking, and partnership with patients and families. As we move through the presentation, we will see how careful history taking, repeated examinations, developmental understanding, pattern recognition, red flag awareness, and longitudinal follow-up work together to improve diagnostic accuracy and patient safety. Next slide, please. A good neurological diagnosis begins before the physical examination. The history often provides the first and most important clues. We need to understand when the problem started, how it progressed, what triggered it, what symptoms were associated with it, and how it affected the child's daily life. In pediatric neurology, the history must also include prenatal and birth events, developmental trajectory, family history, medication exposure, psychosocial context, and environmental factors. A helpful approach is to begin with open-ended questions, allowing the family to tell the story in their own words, and then move to more focused questions to refine the differential diagnosis. This careful process helps prevent premature closure and gives meaning to the examination findings. Next slide, please. A single neurological examination is only a snapshot in time. Neurological signs can evolve, disappear, or become more obvious as the disease process develops. This is why repeated examination is essential, especially when symptoms change or when the diagnosis remains uncertain. At each visit, we should compare the current findings with previous observations and ask whether the clinical pattern has shifted. Systematic documentation is especially important because subtle changes may otherwise be missed. Repeated examination is not simply repetition. It is a way of testing and refining the clinical hypothesis over time. Next slide, please. In pediatric neurology, development is not just background information. It is part of the diagnostic framework. A finding that is normal at one age may be abnormal at another, and normal developmental variation must be distinguished from true pathology. Clinicians need to interpret motor, language, cognitive, social, and adaptive skills according to the child's age and developmental trajectory. This helps us avoid two major errors: labeling normal immaturity as disease and dismissing true delay, plateau, or regression as normal variation. Developmental understanding turns isolated observations into meaningful clinical interpretation. Next slide, please. Pattern recognition is an important part of clinical expertise, but it must be used carefully. We should look for meaningful clinical patterns and syndromes rather than interpreting isolated facts in isolation. The safest approach is to integrate the history, examination, investigations, and disease course, then think broadly before narrowing the diagnosis. At the same time, we must actively search for red flags at every encounter. Warning signs such as rapid progression, regression, focal neurological deficits, signs of raised intracranial pressure, systemic illness, or a clinical course that does not fit the presumed diagnosis should prompt urgent reassessment. Pattern recognition improves efficiency, but red flag awareness protects safety. Next slide, please. Longitudinal follow-up is one of the strongest safeguards against diagnostic error. Many neurological diagnoses become clearer only after observing the clinical course, response to treatment, and emergence of new findings. Follow-up allows the clinician to recognize whether the initial diagnosis still explains the patient's condition or whether the reasoning needs to be revised. Continuity of care is particularly valuable because it helps detect subtle trends over time. Families should also be active partners in this process. They need clear guidance about expected progress, warning signs, and when to seek earlier reassessment. In this way, follow-up converts uncertainty into learning and helps prevent missed or delayed diagnoses. Next slide, please. Uncertainty should not be viewed as failure. In clinical diagnosis, uncertainty is often a useful signal that the reasoning process should be reopened. When uncertain, the first step is to reevaluate, revisit the history, examination, and differential diagnosis. The second step is to re-examine, perform a focused or complete neurological reassessment, depending on the clinical situation. The third step is to reconsider. Keep an open mind and ask whether another explanation may fit better. This approach helps reduce anchoring, premature closure, and misdiagnoses. A safe clinician treats uncertainty as a cue for disciplined reassessment, not as something to ignore. Next slide, please. To conclude, safe neurological diagnosis is built on several key pillars: a systematic approach, attention to detail, sound clinical judgment, continual learning, and partnership with patients and families. These pillars support the practical diagnostic pathway: good history and examination, appropriate investigations, clinical correlation, follow-up, communication, and ultimately better outcomes. The goal is not simply to name a disease. The goal is to reach the most accurate diagnosis at the right time for the right patient, while minimizing harm from delay, misdirection, or unnecessary testing. Safe diagnosis is therefore both a cognitive process and a professional responsibility. Next slide, please. This presentation was selected from the educational archives of Professor Mohammadi. Thanks for watching.